Next is our session on spontaneous coronary artery dissection. And Dr. Wells, who is a vascular cardiologist, will be giving us the basics of SCAD. Thank you.
Thank you. How was lunch? Good? Okay, good to see everybody again. And I always enjoy these conferences. FMD and SCAD societies is the best example I can think of with collaboration between the patients and the physicians. And so this makes it so much fun and productive and collegial. And then you have this sense of community that's like people have said before, like a reunion and all of you getting to know each other and share stories. So really appreciate that. So we're going to, the next session is all about spontaneous coronary artery dissection, or SCAD. And Dr. Morrison had a nice little introductory few slides, which was perfect as we segue into this topic. So we'll start with a case. As a 42-year-old woman with no past medical history, she presented with chest pain for 2 to 3 days, and they checked her troponins, which is that blood test for myocardial injury, and it prompted the heart catheterization. And she did not have any history of heart disease or other risk factors, wasn't on hormones, pregnancy test was negative. And here's her angiogram, her heart catheterization. The first thing you see is that the coronary arteries are kind of tortuous, like a curlicue appearance, like a curly fry. That's a sign for a younger woman that there's some type of arteriopathy or fragile blood vessel. What else do you see there? Maybe right here, this is the left circumflex artery. And what you can see when that fills is that luminal, that narrowing of the mid portion of the circumflex and then some reconstitution of flow there. So that entire mid circumflex, or the mid portion of that artery, is a coronary artery dissection. She did have some chest pain 8 months later and had a repeat heart catheterization. And fortunately, you see recanalization, which is not uncommon for these patients, where the artery looks completely normal. So there's the area where the dissection was in the circumflex artery, and now it looks great. Further screening revealed evidence of FMD, and the patient's doing well with continued monitoring. So what do we know about spontaneous coronary artery dissection, or SCAD? Well, it's non-traumatic, non-iatrogenic. It's not caused by an accident or a catheter, for example. We think in heart catheterizations that there may be up to 1% has a SCAD event, and in patients with chest pain, over 1%, maybe up to 4%, particularly in young patients that don't have traditional risk factors. It's the most common cause of pregnancy-associated MI, and the recurrence rate is 20 to 25% at 5 years, or 10 to 15% at 3 years. And so what causes SCAD? So you see in these cartoons here, there's actually two kind of theories or hypotheses. There's an inside out and an outside in hypothesis. The inside out is actually figure C here. And remember those layers of the blood vessel, intima, media, adventitia. Inside out is where you have the intimal tear, and then it separates into a true and a false lumen. You have blood accumulating in the false lumen, and it creates that narrowing into the true lumen. The outside in hypothesis is a little different cause, perhaps, where you have spontaneous rupture and bleeding from these miniature blood vessels called the bays of Vasorum, and that causes what's called an intramural hematoma, or this blood within the tissues now into this false lumen, and that's also compressing the true lumen. So, and you can see that with the histology slides here, but two different thoughts about pathophysiology there, and both can happen. So a few non-audience response program trivia questions still. Your favorite. What are some of the known precipitating factors or triggers for spontaneous coronary artery dissection? This is just throw some ideas out there. What might trigger a SCAD event? Stress. Vascular load, to increase workload on the heart, stress, and that stress might be physical or emotional, perhaps. Hormone replacement therapy, possibly. Good. Which one? Pregnancy, very good, thank you. High blood pressure and things that could maybe trigger high blood pressure, so a stimulant. Heavy lifting, isometric exercise, heavy lifting. Alcohol, we don't see that often, but perhaps if there was some other trigger related to the alcohol, that's possible. Very good. And we know from some of our studies that we've done is over 50% of the time we can identify, the patient can reflect and identify a potential trigger, and they're most of the things you mentioned. So usually a physical or emotional stressor, exercise, Valsalva, which is bearing down, retching, etc. Emotional stress, someone mentioned, So that there could be stimulants, which could be a recreational drug, or it could be something like an Imitrex that we talked about, or an ADHD medication, or excess amount of caffeine. Hormone replacement therapy perhaps is associated with that. We're not really comfortable with that risk, though. And someone asked that question earlier. We're not sure what the risk is, but that's pretty comprehensive. And I think you hit all of the potential triggers there that are on this list. And pregnancy as well. You're right. Okay, and the gold standard for diagnosis for SCAD is angiography. So we do the heart catheterization. We usually inject some nitroglycerin to make sure there's no vasospasm, which can kind of mimic SCAD or cause some narrowing. There is a type 1, type 2, type 3 SCAD, and I'll show you examples of what that means. Some other tools that we can use is there's sophisticated cameras on the catheters called OCT and IVUS, where you can take a picture inside the blood vessel to see if there's a dissection or intramural hematoma. We use that when there's some diagnostic uncertainty. Not usually, but sometimes we can if needed. Also, if we need a non-invasive test, a coronary CT angiogram can look at the coronary arteries. It's a little less accurate than the heart catheterization, but can be helpful if you're trying to avoid it. And we've mentioned that is really, really important to look for extra coronary abnormalities, including FMD. The repeat coronary angiogram we don't necessarily do. Like I said, most arteries have healed within 4 weeks. Sometimes what I'll do, if there was some diagnostic uncertainty, if we're still not sure if this was plaque dissection or something else, we'll repeat the coronary CTA at a follow-up 1 to 2 months visit. If it was a SCAD event, usually, again, that artery has healed. If it was atherosclerosis or plaque, it's usually still there. So that can be helpful as well. So this is the type 1, type 2, type 3 SCAD. Okay, you might hear us refer to this convention. Type 1 is your classic dissection where you actually see the flap and it creates a double lumen. Okay, you can see that line going through the middle of the blood vessel. Okay, type 2 is your classic intramural hematoma. That's a long tubular stenosis, usually greater than 2 centimeters. And type 3 is a similar type of tubular stenosis, but it's shorter, less than 2 centimeters. And this could be the one that's diagnostically tricky because it could mimic atherosclerosis, vasospasm, and other things. So that can be a challenging one, is type 3. And trivia question, what is the most common angiographic type of SCAD? Type 1, 2, or 3? 2. Good job, Dr. Kim. That's why we're here. You learned something today. Type 2 is the most common, but you're right that our knowledge about SCAD now is much better than it was even 10, 15, 20 years ago. So our diagnostic accuracy is improving. That's recognizing that even though you don't see a flap, like Dr. Kim mentioned, type 2 is the most common. We have to have that index of suspicion when we're looking at the angiograms. And here's some examples of that. So type 1, hopefully you can see with that arrow, that linear streak in the blood vessel that looks kind of white on this, where it's separating the contrast. That is a type 1 dissection that has the flap, right? And you have a double lumen sign, we call it. And again, you can appreciate on some of these heart catheterizations that tortuosity or that curly Q appearance to the arteries, which is helpful diagnostically. Type 2, again, white arrow, you can see the reference vessel above the white arrow is kind of a larger vessel, and then it tapers quickly, and the rest of the vessel is much smaller in caliber, and that's because that entire artery is squished by the intramural hematoma surrounding it. You just can't see it because this is only a picture of the lumen. Does that make sense? Okay, so that's a type 2, and there is, just so you've heard of this, a type 2A and a type 2B. Type 2A involves the mid-segment of the vessel. Type 2B is when it extends to the distal aspect of the vessel. Okay. And type 3, again, this is the one that's a little more diagnostically challenging. You could see with both those images with the arrows, you can see a narrowing. That narrowing is less than 2 centimeters in length, and that could be tricky. Is that caused by vasospasm, plaque, or SCAD? And that's why we sometimes need to use other modalities. This is an example of an OCT, which is that sophisticated camera on the tip of the catheter that takes the picture. And you could see, in this case, the flap, right, where it's separating there at the top of the arrows. Sometimes you can see the hematoma as well, or distinguish that from plaque. You don't always want to use OCT because it can be potentially dangerous putting a wire down a coronary artery, making the dissection worse. So we only use this when needed. Okay, so when we made the diagnosis of SCAD in the hospital, what's the acute management? So blood thinners with heparin and DAPT means dual antiplatelet therapy. That's aspirin and clopidogrel, like you've heard about. There's a little bit of controversy with that. We typically use heparin and antiplatelet therapy for all heart attacks, but once we've made the diagnosis that it's SCAD rather than atherosclerosis, it's more appropriate to stop. There's a theoretical possibility that because this is intramural hematoma and bleeding under the blood vessel walls, that it could worsen or propagate that hematoma, right? So we generally stop the heparin and continue aspirin. We still don't know if two blood thinners, so aspirin with the Plavix is better than just the aspirin alone, and we're actually looking at that with some studies. But most of us are comfortable doing what we call aspirin monotherapy at that point once you made the diagnosis. We do know, however, from observational data that beta blockers like metoprolol, when they're started, decrease your risk for recurrence. So if anyone in the room has experienced a SCAD event, you've probably been started on a beta blocker. And you could see here from this study that at 7 years follow-up, you can see that separation of the curves. That means that the top curve is the beta blocker group that had less recurrent events over time. So that's helpful. That's a medicine we really try to push if possible after a SCAD event. Okay. Like I mentioned, after a SCAD event, most lesions heal within a month or so. That's good, just like you get a cut on your skin, right? And the scar's there for a few weeks and then it gets better and you didn't even know it was there. The same thing's happening in your coronary artery, and the pressure of your blood pressure with the blood pushing that intimal flap back to help it heal, and you have no residual stenosis. That's a good thing. We do need to point out that if you do have a SCAD event, the risk of recurrence, either extending that current SCAD or developing a new SCAD, is the risk is high within that first 3 to 5 days. So we recommend that you stay in the hospital for close monitoring to prevent that risk for recurrence. Okay, that's important to know. In the rare instances where there's worsening ischemia, so persistent chest pain, there's heart dysfunction, there's multiple blood vessel involvement, and we have to consider revascularization procedures like a bypass surgery or stent. That's pretty rare, and there's some higher risk associated with that. But there are certain instances where if the patient is unstable or having persistent ischemia, that we have to consider that. Okay. And here are some examples why it's riskier. So with a stent, for example, there's approximately a third risk that there'd be some type of technical difficulty. So you could have difficulty getting the wire in the correct place. Like I mentioned, you can go into the dissection, you can worsen the dissection. Where you put the stent could squeeze the dissection intramural hematoma both ways. The example uses squeezing a tube of toothpaste, and if you squeeze it here, then the toothpaste goes both ways. That same thing can happen when you stent the intramural hematoma. So we try to avoid that. And you can see some examples in the pictures here where the stent opened up the dissection, but there's still some residual narrowing on one side of the stent or the other. So that can be challenging. And then if you do bypass surgery, there's a risk that bypass graft can shut down as well, higher than with traditional atherosclerosis. But if needed, if the patient's particularly sick and needs that treatment, we consider this at times. Usually we can avoid it. This will be a segue to Dr. Aday's talk, I believe, so how he transitioned from inpatient to outpatient management. So usually by the time the patient's leaving the hospital, you're on an aspirin, you're on a beta blocker, such as metoprolol. We'll recommend cardiac rehab. Okay, so you'll go exercise with nursing and exercise physiology supervision, and that we know that improves outcomes, decreases symptoms, and improves long-term quality of life. And there's some other precautions that we talk about with lifestyle activity, avoiding straining, heavy lifting, high intensity activity exercises. When you get to clinical, I have a discussion about pregnancy and contraception based on the patient's expectations there, screening for FMD with the CTA, and vasodilators for angina. There's certain types of blood pressure medicines like a calcium channel blocker, nitroglycerin, for example, where some patient, a certain percentage, up to 30%, may have some residual chest pain, and giving that extra medication may treat some of that chest pain. What is the most common condition that predisposes patients to SCAD? FMD. Okay, that's why we're here. So this is the original article that showed the relationship between FMD and SCAD. And if you can see from the date, that's 2013. So we didn't know about this until just over 10 years ago. That's relatively new knowledge, and it was very novel at the time. This was done by one of our colleagues, Jackie Saw, who's interventional cardiologist in Canada, and she had a high percentage of SCAD patients, and she noticed when she was doing their angiogram that they had some beating, some FMD like beating in the arm and the leg where she was putting the catheter in, and so she decided to do a study where she looked for beating in all these fit patients, up to 50 of them, and what she found was remarkable. That you can see in that top row, over 80% of her patients with SCAD had FMD. That's probably a bit of an overestimate, but we still think from various registries and studies that that percentage of FMD is at least about 50%. Okay, so if you have a SCAD event, the most common predisposing condition is fibromuscular dysplasia, and that's why we're aggressive about screening for FMD and other occult aneurysms and dissections. And this is just a nice summary, particularly that Venn diagram on the right side of your screen that shows the relationship between SCAD and all these other risk factors we talked about today, right? And we have a lot to learn in terms of our understanding about the pathophysiology and the diagnosis and treatment, but it helps us conceptualize. You have SCAD in the middle in this case, but FMD, other arteriopathies, genetic risk factors, migraine, headaches, pregnancy, and how is all of this related? So we have a lot to learn, but this is kind of how you can conceptualize that risk in your head when we're assessing a patient with SCAD. And this is just a summary and hopefully a segue to the next talk, which is about outpatient management of SCAD. And again, this was my last talk, so I was really, really happy to be here. Love the community you have. Thanks again, Dr. Kim, and please reach out if you need anything, and see you next time. Okay.